So we're going to dive into risk and suicide assessment. And when it comes to this part of our field, it's a requirement. It's not a matter of if it happens to you, it's a matter of when it happens to you.
And I think particularly when we're talking about our first responders, it's important to recognize that they are at higher risk of suicidal ideation and completion, unfortunately. We know that 1% of all suicides are first responders, which correlates to about 250 to 350 people a year. And while, like I said, that 1% may not seem like a lot to those families, it's certainly very important. We also know that based on our statistics, 58% of those are law enforcement, 21% are firefighters, 18% EMS, and 2% operators or dispatchers. Those numbers change. We know from the Florida Department of Law Enforcement that there are some new numbers coming out that are really quite astounding. And I expect that to happen nationwide. So we'll look forward to keeping up as those statistics evolve.
So let's talk through a bit of considerations when we think about working with first responders. And this is where the rapport and the relationship that you develop, it really matters. There's so much hesitation and worry about talking about this. If you think through some of those cultural considerations of this population, that feeling of I'm saying something that makes me feel like I'm a burden, makes me feel weak, makes me feel like I don't have the answers. This is not an easy topic for many to talk about. And so the rapport that you develop really matters here. You need to be sure that you take the time to build it. Don't rush through it. This is one of those pieces that I say, don't rush. You have plenty of time. Build, connect, make sure that your assessment is riding in the vehicle of relationship. Now, it also impacts the career. Think about all the different ways that this could impact the way that they are perceived at work, concerns even from leadership. And in some cases, it might be the determining factor of if they're allowed to stay on the force. So I know that you've mentioned there are some efforts that are coming along with hopefully decreasing the stigmatism around this. But in some places, we're really not there yet.
No, and I agree. And I think going back to that rapport piece too, right? Really being the foundational piece of setting the safety and the trust between the provider and the client, right? Whomever that might be. But particularly with our first responders, we know that they're already hesitant to come forward. And so you really have to be looking for those subtle clues or verbiage that they may kind of put out there to you as a hope that you're going to catch on. And we need to kind of figure that out and help connect with them.
Yeah. So the last is we want to highlight if one of their peers or supervisors refer them to you. These are people that spend a significant amount of quality time with them. They're around them quite a bit. So let's say that you're seeing your client, an hour a week. These are people that are spending 12-hour shifts or more with them every day. And so being understanding that if that referral comes, it's likely even hard for someone to make that referral. So I would encourage taking it seriously, really taking time with the collateral source as well to gather information.
Yeah, and stepping into that with even the releases of information. If you feel like someone has been brought in and you're maybe not getting the full story, asking if they would be amenable to talk with their supervisor, whomever it was, the peer that kind of encouraged them to come in.
So let's bust a myth here. I hear this a lot when it talks about clinicians saying, I want to do a suicide assessment, but I don't exactly want to put that in their head if they weren't really thinking that. First of all, you don't have that much power. So stop it. So stop it. We're not putting ideas in people's heads. We are hearing, and when our red flags start going off, we go, ooh, that language. Ooh, the way you said that. Recognizing the pressure and the burden that you have been dealing with, that's a lot. So asking directly about this, it's not putting it in their head. It's a life-saving statement that you can make to them of like, hey, let me check in about this, right? This is an approach that can be life-saving. And it really encourages, hey, this is an okay thing to talk about. So we're taking all the reins off and we're saying, open discussion, let's discuss this. So I want to bust that myth that you are not putting it in their head.
And just to give an example, I can't tell you how many times I have had clients say, no, but I really appreciate you asking me,
Mm-hmm.
right? So they understand that this is an uncomfortable topic. They also know what an important topic it is. And there's probably not a lot of people in their lives that might ask them
Yep,
that directly. And so there is an appreciation if someone is caring about my personal safety.
absolutely. All right. So, what are those red flags when you think about, okay, I am being attentive to my client, I'm hearing some concerns. What are some red flags? Well, so you need to be observing not just what they say, but also how they say it, those nonverbal indicators. So let's listen to some of the verbal indicators. If they express hopelessness, like nothing's going to get better. The second one I would say is really one that I would highlight with this population, talking about feeling like a burden. These are the individuals where people are coming to them for answers. They're coming to them for solutions. And so when they say things like everyone would just be better off without me, that's a stop and let's eyeball it a little bit more. So you're listening for some of this language, the verbal indicators, whether they even suggested, I just don't want to be here anymore indirectly, then we would still take time to open it up. So anytime you hear verbal or nonverbal, they start isolating, they're a little bit more irritable, maybe some drastic changes in their mood or how they're doing, this would be your sign that you want to dig deeper.
Absolutely. One of the things I also note is when, their colleagues are noting just change in their behavior overall.
Yes.
So, we talked about how often and how much time they spend at their job. So, really taking into account if they say, like, oh, yeah, I've had some people checking on me or noting, that to me is a big red flag, too.
Yeah. Okay, so when we think about being effective in assessment strategies, let's talk about a few pieces. First, the language. Now, listen, I recognize that suicide assessment in general has changed a ton over the past few decades. And watching it progress, we've used different language. So, right now, the term unalive is being used. We are using different ways of saying either suicide or suicidal ideation. So, there's a lot of different language pieces. And instead of stopping and saying the snapshot in this moment of time is we're allowed to do this, or we're supposed to do this, or we're supposed to do this, I'd rather center right back on the client and say, let's be sure to use the client's language. So when I'm doing a suicide assessment, whatever the way that the client uses to identify their thoughts and identify the way they're thinking, that's the client's language is what I adopt. And so it takes some of this, am I using the right terminology? It takes some of it out of the picture a little bit and focuses right back in on the client and what's going on with them.
This is vital because I think there are so many clinicians concerned about using the wrong language rather than just asking the hard questions. And so whether you refer to it as safety, as suicidal ideation, as unalive, right, died by completion of suicide, committed suicide, I know is less popular these days, but however that client brings it up and is comfortable speaking about it should be how we adapt to them.
Absolutely. The other thing is, I want you to be recognizing your own influence on the process itself. So, our beliefs about suicide, our history with it, how much exposure we have to it, even our personal engagement with it, any of the attitudes around it, that all influences the way that you do your assessment. And so, when we're not aware of that, we tend to see that come out in the assessment itself. Let me give you an example. Let's say that your belief is that it's selfish to do this, then sometimes our questions and the way we approach it are judgy. And it starts to be sharp in our tone, or it starts to be closed ended questions that are leading. We tend to see judgment come out in the assessment process, right? So when we start asking questions, it reveals a lot about who we are as the clinician. And so our belief about it changes the way that we move through the assessment process, even up to the point that if the belief is this is very scary, this is a scary topic, I don't feel comfortable with it, then what's going to happen? We might dance around the topic just a bit too much. We might wait forever to ease into it. We might have to see 47 flags instead of one before we really open it up. Let's flip a little bit. What if the topic is scary because you've had your own experience with it? Maybe yourself or maybe someone you know, and perhaps you've had a loss attached to that. Then it becomes that countertransference where we are tapping into our own pain. So we don't want to open it up here in this room. So there's a lot of pieces of our own awareness that if you're not taking the time to work through it, to stay in connection with it, to make sure that it's not influencing you and taking the wheel of your session, you're going to miss out because this is a big piece that we have to address. All right, goal to assess. Okay, the goal is truly to assess and determine those next steps in treatment. Now, I recognize that sometimes the problem solver in us gets really drawn in through this process. But I like to think of suicide assessment more as like we're putting a puzzle together, and each piece we need to see the full picture. You can't make a determination about the next steps and about appropriate treatment if we don't have a full picture in front of us. And I'll give you a great example. I had a client that I would say once the pieces started coming out, oh, it was terrifying. It was a very specific plan, history of attempts, had, access. And that last piece of the puzzle, when it came together, wow, the amount of support that they had around them. Whole family stepped in and said, we've taken off work for the next week. We've surrounded ourselves. We've went through the house. We've removed everything. We've contacted a psychologist. We've contacted a psychiatrist. We've contacted inpatient, like partial hospitalization, all these things. And I was like, wow, not many people even have that piece of the puzzle to put in there. The amount of support that was there and people were willing to step in to support this client was tremendous. So I couldn't make an appropriate determination of what's that next step without understanding every single puzzle piece that was there for this client.
Yeah.
So don't rush through it and dive into problem solving and start with intervention until you have all the pieces of this puzzle and you see the big picture.
And that is sometimes tough to do when you're on the clock, right?
Yes, absolutely.
So I just want to
Absolutely.
acknowledge that, as the provider, a lot of times when you are back to back, you are going to have to make adjustments in your schedules when these topics come up. It's just not, unfortunately, an area that you can fit into your hourly schedule or whatever that might look like for you. So it's important that we be adjustable and flexible as needed.
Absolutely. So the next piece is I want you to be careful with your responses. When people are not comfortable with suicide assessment, or perhaps it's just isn't an area where you go, man, I've not really walked through it in quite some time. What we tend to do is we tend to go into a response theme of like question, 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 which can kind of feel like an interrogation. Can you imagine how well that sits when you're not in a great place? Doesn't sit well. So I always encourage people to practice. So these two are really linked together. If you're not comfortable with some of the questions, and we'll go over them together, but if you're not comfortable with them, say them out loud, role play it with someone, get comfortable practicing, integrating the question, but then also integrating that relationship so that you're building that rapport. So whether it's a reflection or a paraphrase or an echo or an observation, and then opening a question again, so that we're not setting up this question interrogation for our client and making them uncomfortable. All right, effective assessment strategies. You have to maintain a non-anxious presence. I'd say non-judgmental.
Non-judgmental.
Non-judgmental. Right. So we've got to do both. And so one of the ways that I say that, we want to maintain this is being aware of a couple of the key pieces of our delivery, the way we're delivering our responses, whether it's tone, softening your tone. I have a great colleague that says, if you were sitting in front of your best friend and they're hurting and you wanted to comfort them, how would you do that? Do it through your tone. And so we don't wrap our arms around the client, hold them. but we wrap our tone around them so it can be soft and it can be caring. So being really thoughtful about the way our tone is landing. Volume, when we do a suicide assessment, we tend to get a little softer because we're honoring that this is hard for them. Our rate of speech tends to slow down. Our rate of response might slow down as well, allowing them the space to feel it. And then the last is our pacing. As we said before, you might have to make some adjustments to your schedule, but we allow the pacing of the session to be really client led so that they can open up and share as much as they need to.
Yeah, and I'd almost think of this as mirroring, right? You are really
Yes.
trying to role model where you want them to be. So instead of allowing their anxiety and intensity to bring you up to where they are,
Yeah.
your goal is for you to stay grounded in your peaceful space so that they can kind of absorb some of that from you, if
Yeah.
that helps.
That's an
Right?
intervention in and of itself.
Yes, for sure.
Okay.
So we are going to dive into assessment strategies for suicidal thoughts and plans. So, obviously, when we're talking about an effective strategy, there are several different areas of this. We want to first really figure out where these thoughts are coming from. How frequent are they? What is the content? How long have they been experiencing these things? How severe are the thoughts? And what are the contributing factors to that? So really diving in and not being afraid to ask those detailed questions. I think that's where we get hung up, particularly if this is not something you do all the time, is we want to gloss over it. Like, can you just give me a no so I can move on? Because it's a scary topic. Instead of really showing your client that this is a very safe space to talk about even the hardest of thoughts that come to mind. So I always say, the thoughts are not coming from within. You're not creating them. They're thoughts that are coming at you. And sometimes that provides a little bit of relief from them that they're not doing this to themselves, right? And take some of that judgment off of them. Next part to look at is if you are getting some feedback that, yes, there are some suicidal thoughts and they're responding positively to that, you want to move into the plan. What is the plan? Have they thought about that? Is there a means? What's the lethality of the plan? Have they begun to prepare at all? Have they taken action? What are the behavioral measures that you can really take note of putting things into place to complete this plan? So this is where you really want to spend some time. It's going to help you determine what your next level of support is, right? So, if there's a plan, you're going to go to a higher level of care, whatever that may look like for that particular client. That can range from having someone who's going to stay with them 24 hours a day and make sure that you've removed means of lethality to putting them in the hospital, unfortunately. And sometimes we can have someone do that voluntarily, and sometimes we have to do that involuntarily. And those are obviously two very different routes. I do think I just want to go back to what you said earlier about the rapport is a foundational piece of creating the trust that it takes to walk someone through a voluntary hospitalization. So if you can have that strong relationship, and I always speak directly to my clients about our relationship and our dynamic and the trust that we're working to develop, so that if something needs to be done, that we're going to work together to do that in the least traumatic way, right? We're going to make that the most comfortable process. They're going to be assured that they have follow-up services and that they're going to get support through that process. So obviously, again, that support piece, as you mentioned, having a family and friends and people who are available.
Well, let me pause before we go that, because I want to make sure that we hit with plans. I always put an S there because it never fails that individuals don't just have one plan. And so I think we as clinicians, we kind of get locked into the terminology, like, what's your plan? What are you thinking? Right. And so I always say, make sure that you have used the word plans or you've used the terminology, what else?
Right.
What else?
I would agree with that. That yes, sometimes you get locked into one thing they say, and then you forget to ask that, like, are there any other thoughts you've had, any other plans that you may have put into place?
And sometimes they've even evaluated. So there's already a plan that was evaluated. I have one client that we walked through multiple plans. Well, I thought I could do this, but then that could end up really being painful. Like if it didn't if it didn't really work. So I thought about this. So we've walked through multiple plans. So when we get locked in, we missed the opportunity of making sure we've evaluated all the different ideas that could be on the table so that we're aware of them. And it also gives you an understanding of how deep they've gone into the preparation, the planning, the thoughtfulness. If they have a history and they say, I tried that, didn't work, I want to try something different, it gives you a lot more understanding of how much time and they're spending in this space. And the other piece too is, making sure that you take the time to look at that plan and what the goal of it is. Make sure it's not non-suicidal, self-injurious behavior, but it's actually wanting to end their life.
Yes, those are two separate things. So
Yep.
determining the difference between would be important.
Yep.
And then again, as you begin to rule in or out how lethal those plans are, and sometimes non-suicidal injurious behavior can lead to accidental suicide.
Yes.
So,
Yes.
Again, kind of assessing where they are and the means of that lethality
Yes.
might determine what kind of support you put into place next as your
Yes.
next step. So determining, is this someone that I need to have daily contact with? Is this someone who needs weekly contact because they have plenty of support outside, or they have declined that they have any plans at all? So that is going to be up to you. I would really, really impress upon the fact that this is a time for peer supervision, that you consult with other providers and check in, say, here's what's going on, explain the situation, go through all of these steps and get some feedback on what's the next step. How can we decide this? Are there more questions or more feedback that we need from the client before we make a determination? Or is this something that we can go ahead and plan the next step for?
Yeah. And also look into what supports that your client actually has, right? Do they have a ton of supports around them? Are they incredibly close, wonderful contacts? Or are they like the neighbor next door that I don't even know their name? What level of transparency do they even have with these supports? Some people, they'll say, well, I have, my partner lives with me, and she's a great support, but I would never tell her that I'm thinking of this. Well, that's not a level of transparency I feel great about. So, it's like, well, who would you tell if you got to this point of wanting to act on it? So identifying those. Another piece is, if you did implement intervention, are they now going to tell the person that they are thinking this so that they truly are a support for them? There's a lot of levels here when we think about assessment. Again, you hear all the puzzle pieces coming together. This is not, if they say yes, I hospitalize them. That they thought about suicide, I'm hospitalizing them. It's, I'm getting all these puzzle pieces so that I know the appropriate treatment level that would be great for them. And I now make steps forward to ensuring safety and working through what they're going through.
Right. And there is not one way that's right for any particular person. So I think it's always really important, although we have frameworks and guidelines that we're going to get into and assessment strategies, that we really look at every person as an individualized case and make the best determination for them.
Absolutely.
So moving into those effective assessment strategies, we want to make sure that when there is a trauma-related thing that is we are asking about the specific event, that we don't want to re-traumatize a client accidentally.
Yes, we don't want to go with too many questions too fast. Right. So remember rapport, think about pacing. The client leads the pace, right? We don't want to re-traumatize them. So if their suicidal ideation is around a traumatic event, if you have not been in yet in the details of that, be mindful. We are not reopening the wound during an assessment. Remember, the goal of the assessment is to determine where we're going next. It's not reopening and reprocessing the trauma. So I want you to be really mindful of that when we think about assessment. And the next piece, kind of, in some sense, I would say is the biggest component for this population, is what is confidentiality going to cover or not cover, right? You need to be really clear what it covers. So outline where it will be breached, what you will be doing, so that they know. This is another piece of how we truly build rapport, is we are transparent in the process itself. Even you can walk through the steps. If it's breached and we determined, this is what we need to do, here's what it will look like. it goes a long way when you, as the clinician, are going to be honest and clear and transparent about what's going to happen. If you don't know what happens, for you as a provider saying, well, I don't really know what happens when somebody goes to the emergency room with suicidal thoughts, or they go to inpatient. I don't really know what it looks like. Get to know your neighborhood.
Yes.
Go out in your community, venture past the Zoom world, and go and talk to these other facilities or programs in your area to say, walk me through what that looks like. At least call them and get an idea so that you can be a source of information for your client instead of you both are walking through the dark.
Yeah, I don't think we can ask for transparency from them if we're not being transparent ourselves.
Right. All right. So how does all of it come together? Right. We've talked about a lot of different pieces of this puzzle, but that's a lot to remember. Like, can you imagine your hand just full of random puzzle pieces? That's a lot, right? So now it goes right into this little assessment method that I'll say is an easy thing to remember. Horrible acronym, SLAP, like that's horrible acronym, but at the same time, it's an easy thing to remember. So we're going to walk through this. So specificity, when we think about that, we're looking at how specific is the plan? What are the specific pieces they've thought through, right? Getting an understanding of the method, and then going through each component of how lethal is it, right? How is this something that we should, if they are using a gun, that's pretty lethal, right? I had a client say, I'm going to, take melatonin, and it was like, had to look into it. You need a bathtub level of melatonin to overdose on it. So I was like, wow, that's a lot of pills right there. So lethality was a little different there, right? Availability, how available is it for our first responders?
Right. And that's what I was going to say. I think for
you.
some of these, it is tough with this particular audience. We're talking about the lethality and the availability are pretty
Absolutely.
Even proximity, right? Our last one. So, having those things ready to go is not a far leap. And maybe this is part of the reason that they are at higher risk, right? They are just constantly surrounded by opportunity.
Yes,
and so we just really want to make sure, again, that we're able to address each of these things specifically. We know they are going to have some of these things. And so it is tough to determine when to take away weapons from this population, because they are going to be resistant to it most of the time. They will want to continue to do their work. And so you have to be, again, really have a great level of trust and rapport with them to be able to say, how can we move around this? How can we take a few days off? Can we give them to a friend or a colleague or something where we can work things out to keep them safe until we can get them back on board? Because that's always our goal.
Absolutely. So the last piece of the puzzle is proximity, and that's who's close to them, who's around them that can serve in that support role. Now, I will tell you, there's a lot of questions here on this slide, right? Of how do you go through each one? And as a reminder, if you are not comfortable with them, if you've not said some of these out loud to another human being, then I would really encourage you to practice. Take some time. Make sure that they feel comfortable to say that you notice any tension in your body or any discomfort when you're saying them, so that you can address that now before it happens when you're with a client.
Absolutely. Okay, so now we'll dive into the SAD person scale. This is a widely used tool for just really looking at risk assessment. And it is structured in a way where you can kind of just step through, is this person more likely at risk than the average? So we'll move into that, looking at sex as the first thing. We know that males are more statistically likely to complete suicide, with females are far less. They are more likely to attempt, but not to complete suicide. Moving into age, those under 19 and over 45 years of age have a significantly higher risk. So we're just kind of looking at all these. I know we often talk about when we're doing case conceptualization and so forth, if we're concerned about a client, we're like, okay, well, it's a white male over the age of 45. Let's keep a little closer eye on this person. Obviously, adding depression to that mix is going to be a major risk factor as well, because they're just more likely to attempt or complete suicide. So moving into the person section, we're going to start with previous attempts. So if they have a history, I always say past behavior predicts future behavior, right? So if someone has had an attempt in the past, they are more likely to make an attempt during another downward spiral. So we'll keep an eye on that. Ethanol use, so alcohol or any kind of other substances, is strongly correlated with attempts and completions of suicide because we know it's going to impair their judgment. They're going to make poor decisions during that time. And unfortunately, that's a lot of people use that as their escape or their way of numbing their feelings, but it does put them at higher risk. We're talking about rational thinking loss. So anyone who's having some severe mental health issues, including psychosis or delusions, or even severe anxiety, again, those are someone that we are going to keep a close eye on. Let's talk about social support. As we've mentioned several times already, it makes a huge difference. I always call this is like the moderating factor. If you have people that care about you, and we will get into at some point how isolation plays a huge role. I think in this population particularly, right, a lot of first responders feel isolated because they are the fixer. They are the one who's supposed to be helping others, and they don't see themselves as someone who should be reaching out and asking for help. And so if they don't have that social support on top of things, or they're just not likely to use it, they're going to be more vulnerable to the situation. O is your organized plan, right? So if someone has a specific plan, so we talked about specificity before, right? And having a plan that is available to them, we know that we need to keep an eye on them. And then N is no spouse. So not having a partner, again, we're talking about how important connection is and support system is. That's going to be a huge piece of the puzzle. Within the first responder community, we have a lot of young professionals in this area. And so oftentimes they don't have a spouse. We also know that their divorce statistics are higher. So in that way, they may not have a partner to turn to. So something to keep a lookout for. And then lastly, illness, right? Being sick. So if you have that that could include any kind of chronic illness or debilitating medical complication, any sort of terminal disease, something that is chronic. So chronic pain, even like that could be back pain or something that we see pretty often in this population due to wearing heavy equipment, and gear. So we want to hone in on those folks. Now, we will take that as an assessment. You put that together, you will give the points. And there are some people who do not like sad persons because they don't like it being reduced to a number. That, of course, is not meant to minimalize or demean anyone by putting it as a number, but it just helps you to understand where they are on that risk scale. So it is a screening tool. It's not going to be used as something in isolation or alone. You're going to be asking a lot of questions outside of these things, but it is a good thing to keep in mind as you're working with someone to kind of determine their overall risk factor.
I think it's helpful too, if you have a session with a client, you don't necessarily need to tell them the scale number, what their number is, but it's great for adding to documentation as well. So as you're going through, giving 1 point for every letter and then adding it up, you can add it into your documentation to support what your next step is. But again, this isn't about necessarily finding treatment. It's about completing the assessment and knowing what the next step is for the appropriate treatment level.
Yeah, and moving into that, right? If you are concerned, if you're having someone who's moving along on the scale, or you find that you might want to be asking more questions. This is a very popular scale, the Columbia Suicide Severity Rating Scale. This is an evidence-based tool. It's used worldwide. It's very common. And what I like about it is that the questions it's going to ask are very easily put into conversation. We were just talking about how so many of these scales are easily and widely used just to kind of get the paperwork done. But really the meat and potatoes of any of this is having the conversation to follow it. So, if you are uncomfortable, we talked about kind of having those conversation prompts earlier on. This is a great tool to use as a conversation prompt. If you're not sure of how to ask the questions, this is going to lead you through. And I think it makes it very easy and succinct in that way. So along with that, another approach, and this is maybe a bit more conceptual in approach, is assist training. So Again, this is something that you can train anyone in. You do not necessarily have to be a provider. This could be peers, this could be chaplains, but it's a wonderful 2-day training. I think they have in over 100 countries. And the reason that it was developed is that because it can step you through getting help for any kind of person that might be at risk to leading them to a professional environment who can make a determination about next steps. The idea of recognizing invitations for help. So again, we're looking at those subtle verbal hints, right? So it might be that someone's acting a bit out of character. There might be situational cues that you picked up on, they're having some relationship trouble and now they've been acting a little off, or they're not showing up to work on time, or, whatever it is that they're saying. It's a cue to check in with that person and start doing other assessments. Like maybe you then go to the Columbia and start asking those questions, but that's going to help you go to this, the next step, right? Asking directly about suicide in a clear, a compassionate way to just bring it to the forefront. It does not have to happen in a silo, in silence, where these people don't feel heard. The next part is about building an immediate safety plan. We're not talking about that this particular person is taking on the care and the treatment of this person. We're talking about how can I keep you safe right now until I can figure out what to do next, right? And so yes, you really want to reduce that immediate risk and make sure they stay safe. And then you lead to connecting them with resources. Who do I go to? What place do I know? What providers are available? And this, I always say, this is sometimes the hardest part. And you're going to see this in several different frameworks of you must know your local area resources. You have to, I think that is one of your responsibilities as a provider, is to know how, if you don't have the answers, how do I pass this person on in a transition that is safe and that feels like quality care for the person that you are treating. And then lastly, of course, follow up. So if you do have to hand them off, whether that be to another provider, a supervisor, a hospital, that you are the person who is going to then follow up and say, hey, I know we made this transition, just want to check in. How's it going? Have you connected again with them? Are you getting good treatment? How are things going for you? That is just good human care, right?
Absolutely. One thing that you might want to keep in mind is if you have the opportunity to work with organizations or a peer support team in this community, that you actually could offer this as this is how we address when suicide comes on scene.
Yeah, and that assist is a 2-day training. And like I said, anyone can take part of that. Leading up to maybe a more umbrella type approach is our zero suicide framework. And you will see this as an organizational approach is really kind of an up and coming discussion about how larger organizations support their employees and their teams. So we're going to start this. It shows you a nice little wheel of puzzle pieces. We talked about before, all the puzzle pieces, right, of trying to serve someone. And I think when we're talking about large organizations, the fear is that someone is going to slip through the cracks. So when we talk about a zero suicide framework, again, let's just dip into the language piece. I know there's some controversy about naming it zero suicide. It does not mean, unfortunately, that we're going to save everyone, although that would be our ideal situation. It is meant to be aspirational, right? So the idea is that every suicide counts, it matters, and that we're going to learn from every experience. So we're starting with the lead. If you see that kind of pink colored puzzle piece, the leaders in your organization set the tone for mental health and behavioral health care. So do they believe in that? Are they willing to discuss what happens when someone is suicidal within their organization, what kind of care they're going to receive, if any punitive factors might be in place, so that we can try to eliminate those the best possible. As we lead into train, we're talking about training as many people as possible within an organization. We want everyone, if possible, to go through some sort of peer training, assist training, to know how to work with the Columbia, all of these little pieces that we have in place that create a very large network for how we deal with any kind of suicidal person within our organization.
It's really great for breaking stigma. It's great for making sure that suicide doesn't stay in silence.
right?
Mhm.
And then we'll move into the identification, right? So how do we identify those folks that are at risk, right? We've talked about some of the
Mhm.
assessment tools that we can use, but really using some evidence-based strategies to identify those people that we may need to be keeping an eye on. Next is engage. How do we get folks to engage in
Mm.
care? Is there access to care? Is that care convenient to them?
Mhm.
Are they going to take advantage? If you have people working 24-hour shifts, do they have weekend care available or evening care available? Do they have telehealth
Mhm.
available? So making sure that we have culturally competent, right, accessible care for all of our first responders in this respect is very important to engage them in this process of even being willing to reach out for help. Treatment, again, making sure that all providers that are included in your organization are properly trained, that they're using the evidence-based treatment, and that
Mhm.
you're treating not just PTSD, anxiety, depression, substance abuse, but that you are specifically treating the suicide itself. So that is a little bit of a different animal. So we don't want to just gloss over it by treating a larger picture. We want to make sure we are specifically treating the suicide with evidence-based actions. And then transition. So again, if they are transitioning, whether that means within treatment of coming out of a hospital or
Mhm.
coming out of a program of some sort, or transition as in life transition. Maybe they were off duty. Maybe they've got a return to duty. Maybe there's medical leave
Mhm.
involved. Maybe they're retiring. Huge transition. So looking at those transitional pieces and making sure they don't fall through the crack, that we are following up and engaging with them, which lastly leads us to improve. Every interaction is an opportunity for changing the landscape of your organization. We really want to make sure that we're using some data and looking at the quality interventions that are in place, making sure that people are happy with the services that are being
Mhm.
offered to them, the benefits that are available to you, and just keeping a track on every situation, whether unfortunately it has been a failed situation and there is a completed suicide. We definitely want to investigate those as well, but also those that we are able to step in. And we like to think that every suicide is preventable, and
Mhm.
work on from that mindset always.
Always looking for ways to get better so that we can better serve.